A very big welcome to everybody. I'm delighted that we are doing our first webinar for young people with MPNs. And we have a very exciting program, and I'm going to be very brief because there's a lot to get through. But we do have to thank these wonderful clinicians, Professor Claire Harrison, Dr. Anna Godfrey, Dr. Jonathan Lambert, Gavin, Maynard-Wyatt Health, and also, last but not least, the wonderful Alice Watson, who's the inspiration behind the Young Patients Network. Thank you, and a warm welcome to all of you from Australia, from Canada, from America, from Europe. We're delighted that you've come to join us. Next slide, please. Just very, very briefly, because I'm actually going to direct you to the website, www.mpnvoice.org.uk, to get a full view of what we do. But we're here to serve the entire MPN community, patients and healthcare professionals, and to provide accurate and up-to-date information which is medically verified. We support our families and patients with the website, with forums such as this, and face-to-face forums, online support through Health Unlocked, YouTube, Twitter, Facebook, Instagram, vlogcasts, young people blog, CNS support groups, buddies, MPN patient one-to-one peer support with approved buddies, advocacy, hugely important to us because it gives the patients a voice. It also is a way of networking and working collaboratively with other organizations, particularly in Europe and with the pharma companies. We do printed information with booklets and resources. And the most important thing as a patient, we fund research projects. Now, I'm not going to speak anymore, but please do ask any questions about MPN Voice or go through the website. And I'm absolutely delighted to welcome and introduce you to Alice Watson, who really is, as I said earlier, the inspiration between the Young Patients Network. Alice, welcome.
Thank you so much, Nona. Hello, everyone. It's really nice to see you. Fantastic that you're able to join us. I'm going to be giving you a brief introduction into the Young Patient Network, which we established earlier this year, before showing you an interview that I recorded with one of our Young Patient Network members called Chelsea, who's a fellow patient with ET. And just to say, myself, I'm 28, and I was diagnosed with JAK2 positive ET 7 years ago. Next slide, please. So just to give you a little bit of background about the network, if you've not heard about it before, over the last couple of years, I've been writing an online blog for MPN Voice, just about my own experiences of being a young person with an MPN, but also to touch on and write about some of the topics that are unique to young people with MPNs. And one of the special posts that I did last year for September Blood Cancer Awareness Month was this special collection of young patient stories, which featured 12 young people, both in the UK and the US, who kindly agreed to share their story. And it was this post that really made me think it would be really valuable to create and establish a formal network that could connect us all together. Next slide, please. And so the network emerges out of this recognition that being diagnosed with an MPN at an early age can bring with it a unique set of questions, issues, challenges, and concerns. And the network therefore has three simple aims: to bring together and support young MPN patients, to provide a welcoming space where young patients both in the UK and around the world can meet and connect with each other, and finally to offer information tailored to young patient experiences and challenges. And that's where today's webinar comes in. Next slide, please. So we've established a Facebook group, which is really exciting, and it's got 124 members from all over the world, and that's across the full spectrum of ET, PV, and MF. The group is exclusively for young patients who are diagnosed with an MPN under the age of 40, and it's a digital space where young people can connect, share their stories to diagnosis and their concerns, and ask each other questions. And it's important to say this group is moderated by the charity, just like Health Unlocked, and it has some mandatory joining questions about your age, your diagnosis, and your adherence to the group rules. And if you're not yet a member, but you qualify and you'd be interested in joining this digital space, I'll be posting a link in the chat, which you can then click on and join. Next slide, please. So now I'm going to introduce you to Chelsea, who's a young person with ET, who very kindly agreed to share her journey with me. And so I'm going to let you now watch my pre-recorded interview with her.
For taking the time to chat to me this morning.
That's fine.
Perfect. It's no problem.
My first question really is, could you just introduce yourself for anybody that doesn't know you, whereabouts in the UK you are, what's your age, what do you do, and what your interests and hobbies?
Of course. Yeah, my name's Chelsea. I live in Essex. Basically, I work for a software company, and my hobbies are I'm really into fashion. Like, I post a lot of outfit pictures on Instagram. I love reading, music, food, and reality TV.
That's great. And I have to say, for anyone that doesn't follow you, Chelsea, you're amazing on Instagram. Definitely give Chelsea a follow. All your outfits are incredible. So Chelsea, we obviously know each other through MPN Voice. When were you diagnosed with an MPN?
It was early 2021, because at the end of 2020, I had to have a blood test for something else, and my doctor picked up the high platelets, so he referred me to haematology, and I had loads of different tests and everything, and I was diagnosed. It was probably around March 2021.
Mm-hmm. And you've described there a bit of a short journey towards your MPN. There was just a blood test that picked it up. Was there anything else? Did you have any symptoms at that time that you were investigating that have since been linked to an MPN?
Yeah, for a long time I had the visual disturbances and headaches, but because I had a blood clot on my brain in 2014, I thought a lot of it was to do with that. And at the time, they couldn't find any sort of blood disorder or anything during the time of my blood clot. So they just kind of put it down to the pill, and I had to stop taking that. And then just after that, I was always tired. Just sort of struggled and used to get kind of more tired than other people. I just thought, maybe I'm just a lazy cow or something. I don't know.
No. What MPN were you diagnosed with?
ET.
Okay, and could you give us an idea of what your platelet count was like when they picked it up?
Well, it was over 1,000. I don't know, can't remember exactly how high it was at the time. And then they put me on interferon, and that reduced it down to in the 600s. But they kind of sat there for a while, and then they started creeping up again. So they just kept increasing my dose, but it just didn't seem to work. It's like my body seemed to kind of get used to it. So then I was put on Anna Godfrey, I think it was April this year.
And how are you getting on with anagrelide?
It seems to work a lot better. Touch wood, it carries on. My platelets have gone all the way down. They're in the early 400s now. They did go down a bit further, but now they've crept up. But they seem to be staying there. Touch wood. And some of my symptoms have reduced, like the headaches have reduced dramatically, the visual disturbances as well. But I have got a few side effects with the medications. That's the only thing, but they're more manageable than the ET symptoms were before.
Mm. And what have the side effects been like? How have you been able to manage them? I know you've not been on anagrelide that long, but have you done any lifestyle changes or top tips for managing those side effects and symptoms?
I just kind of try and take it easy when I can. I don't plan sort of too much together. I try and exercise at least once a week. Try and have a fairly balanced diet, but I am a bit of a snack addict. Try and drink loads of water. Try and look after myself, really. Yes. Probably the best advice I can give.
And what impact would you say your MPN has on your daily life?
I work full time, and my job can be quite sort of intense and demanding at times, so I do struggle because I get a lot of brain fog, and it seems to have got worse maybe over the past couple of years. So it can be a real struggle some days. Some days I just can't think, and it takes me forever to work things out. So that could be difficult.
And has your employer, I don't know if you've disclosed it to employer, it's a really tricky issue for young people who are in full-time work, having to manage a chronic disease at the same time.
Definitely.
Has it had any impact both in terms of thinking about your career or the kind of work-life balance that you have?
Yeah. I mean, I don't want to do a job that's too stressful, to be honest. And also, I would like more of a work-life balance. I mean, I try to do my hours and not do much longer, because I think rest when you've got like chronic illness is really important. So yeah, try and stick to that when I can.
Absolutely. A bit of a deeper question, Chelsea, but I wondered if your MPN has an impact on your mental as well as your physical health.
Yeah, definitely. I suffer with anxiety anyway, and like obviously this just kind of makes me panic a bit at times, and like when you think about kind of the future, that's a bit worrying. But yeah, I just try to kind of focus on the present, really.
Have you had any support with that? I don't know if you know, people talk about meditation or yoga or some relaxing podcasts and things. Has anything been particularly helpful for your anxiety?
I mean, I listen often to the Calm app, especially when I'm trying to sleep. I listen to like meditations on there, and that does help calm me down. So definitely worth a try, like for other people who suffer with anxiety.
Yeah. And I wondered, I mean, it's really difficult, isn't it, when you've got an MPN, because it's the unknown in the future. And I wonder, is it transformation that worries you the most, or in terms of what medication will I be on, or what kinds of worries would you say the MPN brings for young people?
It's a bit of both, really. It's I mean, I've tried 2 different medications, and I feel like the only other option is chemo, which I really would prefer not to have to go down that road. So it's the worry that my body will get used to the medication I'm on now, and then I'll have to try something else, and obviously progression as well. Like, what will happen in the future? Will it get any worse?
And I think a lot of young patients that we've spoken to, you know, really share those concerns and worries as well. And that brings us on to the young patient network that's really in its infancy. It's only just been started, but we've got the Facebook group, which has over 100 young patient members from all over the world, all aged under 40. And I know you're a member of the Facebook group. We've had people kind of sharing their stories and experiences and asking each other questions. And I just wondered, have you found it beneficial thus far, and in what kinds of ways?
Yeah, definitely. Because it's really good to hear from other people like going through similar sort of things, and like to relate to them. And it's kind of like a sense that we're all in it together. So yeah, definitely. It's because like obviously I don't have none of my friends or family are going through anything similar. So like I can obviously talk to them about it, but they don't quite know what it's like. So it's just really good to have access to loads of other people who are going through similar experiences.
Yeah, people who are walking in the same shoes as you are.
Yeah, exactly.
That's great, Chelsea. And my very final question was, if you had one piece of advice for a fellow young patient, what would it be?
Just try to look after yourself, take each day as it comes, try not to worry too much about the future. I know it's easier said than done. And yeah, just reach out to other people going through, you know, similar experiences. And if you're lucky enough to have access to maybe like nurses, haematology nurses, if you have any concerns, speak to them, because I've found that they've been really helpful in the past. Yeah,
thanks, Chelsea. Really appreciate you giving up your time, and it's great to chat to you as always.
No worries, Alice. Thank you.
Just to say huge thanks again to Chelsea for giving up time to speak to me, and really appreciate you all listening. And I'm now going to pass to Dr. John Lambert, who's a haematologist at the University College London Hospitals. John.
Thanks very much, Alice. I think it's an absolutely inspirational video, to be fair. It captured so much and actually made my talk quite a lot easier. I was slightly daunted by having to I'm going to be talking on an overview of MPN in 15 minutes, but I think actually you've captured quite a lot of it already in that interview, so thank you for that. So I'm going to focus on what MPNs are, what causes them, and if the causes are different in younger people, how MPNs are diagnosed, and then what the main problems that we see in people who've got MPNs. So first thing to say is MPNs, or myeloproliferative neoplasms, they're chronic blood disorders, and essentially they're due to overproduction of basically mature blood cells. So unlike some other blood disorders, such as acute leukemias, where we get lots of very immature and abnormal cells, in MPNs, basically the cells themselves, they look normal, they behave more or less normally, but there's just too many of them. The three main types I'm going to be focusing on in the next 10-15 minutes are PV, polycythemia vera, too many red cells, but basically due to an elevated hemoglobin. ET, we've got too many platelets, and myelofibrosis, where essentially there's too much scarring, particularly in the bone marrow, which often results in low blood counts. There's a few other entities which are much rarer, as we'll come on to. We've got mastocytosis and hypereosinophilia, and then some overlap syndromes. These are all forms of blood cancers, but in most cases they don't behave as cancers, and I'll come on to that towards the end of the talk. So this is American data just showing the relative incidence of very different MPNs. Now this is in all ages, and you can see in all ages that ET and PV are by far the commonest two subtypes, and we see around 1 to 1.5 new cases per 100,000 people of each. So that's in the UK, a few thousand in total per year. Myelofibrosis is much rarer. It's about 0.3 per 100,000, and mastocytosis and hypereosinophilia much rarer still. So that distribution is a little bit different in younger people. So this is a paper published earlier this year, essentially showing in the black bars patients under the age of 40. And you can see that actually in younger patients, ET is much commoner than PV. So this is quite a well-described phenomenon that in amongst younger people, particularly under 40, there's a lot more ET, and it tends to be more women than men as well. Myelofibrosis, as you can see, is a much rarer entity in younger patients. Now, I tend to think of ET, PV, and MF as kind of three corners of a triangle, if you like. So lots of people will have, if you like, pure ET, where they've got too high platelets. Some people have got too many red cells. And then myelofibrosis, we've talked about too much reticulin. But they are not absolutely distinct entities, and people can move between them. So, for instance, people who start off with essential thrombocythemia can develop a high hemoglobin and develop polycythemia. Equally, someone who's diagnosed with polycythemia can slowly develop elevated platelet count, and particularly for being venosected and they become iron deficient, their platelet count often goes up. And so they can develop what's called polycythemia vera with thrombocytosis, which is at the halfway house. And likewise, there are some people that look like ET, but if you do a bone marrow biopsy and certain other blood tests, it has some fibrotic elements to it, so it might be a bit more like myelofibrosis. So we call that prefibrotic myelofibrosis. It isn't myelofibrosis, but it's somewhere on that spectrum. So I think that's quite an important concept I try to explain to the patients that I see in clinic, that people can move a little bit along the spectrum, and that doesn't necessarily mean that they're going to move inexorably towards MF, but quite a number of patients in the clinic whose condition has moved a little bit from ET towards myelofibrosis, but then stops and stays there for many years. So it can be sort of a dynamic process, and then can go quiet again. Now, we tend to think of MPNs as a diagnosis of older people, and I think that's true. This is a Swedish study from published about 3 years ago, which clearly shows that the most common age to get it is somewhere between about 60 and 80. But you can see that there is a group of patients, and depending which sort of study you look at, up to about 15% of patients diagnosed with the MPN will be aged less than 40. So, particularly what I didn't mention earlier, actually, the number of people being diagnosed with MPN seems to be slowly increasing. And so gradually, this cohort, if you like, this population of people who were diagnosed with MPN at a younger age will slowly increase. So the next part, what causes the MPNs, and are the causes different in younger people? So very, very briefly, all of us have got our blood cells, all of our cells, but in particular blood cells derived from stem cells. And what happens if people don't have an MPN is that stem cells gradually mature, they develop into progenitor cells, eventually develop into platelets, red cells and platelets there. In people who've got an MPN, what happens is that something happens here which causes that these progenitor cells to multiply up, to become too numerous, too many of them. They copy themselves too quickly, and that means that they produce too many red cells or too many platelets. And in the case of myelofibrosis, what seems to happen is that particularly the platelets and the platelet precursors secrete a hormone that makes the bone marrow become too fibrotic. Now, what these are is a driver mutation. That's something that basically causes the stem cells to change, or as they develop progenitor into progenitor cells, it means that they copy themselves too quickly. So what are these driver mutations? Well, I'm sure you'll know a lot of them already. So these are the three commonest ones, JAK2. So these are genes which we all have, but they become mutated. And in particular, the calreticulin, JAK2, and MPL on MPL. And the key thing to recognize is that these are acquired mutations. So sometimes when we talk about genetics and genes, genetic mutations, we have a tendency to think about things as inherited, things that people inherit from their parents, like somebody, for instance, with hemophilia or sickle cell disease. Those are kind of more classical inherited disorders. These are not. These are things which have basically developed, they're copying mistakes which our stem cells have made over the years, and then cause the mutations to arise. It's very, very rare for people to have an MPN due to an inherited disorder, but almost exclusively acquired mutations. And you can see that in PV, most people will have a JAK2, what's called a V617F, an exon 14 mutation. There are some rarer JAK2 mutations we see in PV. In ET and myelofibrosis, about half of people have a JAK2 V617F mutation. The rest will have mostly a calreticulin mutation, and a few will have MPL mutations. Now, the ones at the top here who don't have any mutations, we often call triple negative. That's to say, we can't discern any driver mutation. And Anna's done a lot of work, Anna Godfrey's done a lot of work on this, trying to characterize this group better. But basically, we don't really know, in many cases, what's causing it. Some people might have myeloproliferative neoplasm at all. Some people may do, we just don't know the cause yet. Now, are the causes different in young people? The simple answer is no, not really. Almost all the cases are due to acquired mutations. So they're not, in the vast majority of cases, due to something that people are born with and not inherited. But although the driver mutations are the same ones, calreticulin, JAK2, and MPL, calreticulin is actually a lot more common in younger people. So let me try. So if you look at patients in ET, this is a study from the US about 5-6 years ago. If you look at the green bars, that's patients aged over 60, and the blue or purple bars are patients aged under 40. You can see that JAK2 is by far the commonest mutation in older patients. In younger patients, JAK2 isn't that much more common than calreticulin, and also you've got relatively more triple negative patients as well. If you look at myelofibrosis, you can actually see calreticulin is more common than JAK2 in younger patients, whereas in older patients, JAK2 is still the commonest mutation. So that tells us that calreticulin is usually, or often associated with younger age. Having said that, there's of course lots of people with ET and MF who have a JAK2 mutation. Inherited causes are exceptionally rare. There's some people diagnosed with what's called Stuvash polycythemia. That's the cause of polycythemia, which is inherited. It's a classical way, and there's a few very rare other patients. But I can think in the group of patients who we see at UCLH, which is probably about 750 patients, I can think of 5 who've got an inherited cause, which tells you how rare it is. We do sometimes see familial clustering amongst patients with MPN. That's to say, sometimes, let's say, 2 siblings or a mum and a son or other first-degree relatives have got an MPN. We don't really understand what that is. They don't necessarily have the same mutation, for instance. So it may be some inherited predisposition to get it, but it's not a true inherited thing. This is a little bit commoner in younger people. We could possibly talk about it later on, but it is still, these are still acquired mutations, and generally not things that parents can kind of transmit that down to their children, for instance. How are MPNs diagnosed? Well, I think we've all seen that in the previous interview. So probably the majority of people are diagnosed when they're being investigated for symptoms, or it might be after they've had the blood clots. particularly if it's a blood clot in an unusual area or blood clot in a sort of younger age. But the symptoms can vary quite markedly. Fatigue is by far the commonest symptom. These are symptoms of presentation. So when people are diagnosed, early satiety, that means they're trying to have a big meal, but people feel full before they manage to finish it. Inactivity, itching or pruritus, sometimes caused by water, but not always. We heard about concentration problems and difficulty focusing. Night sweats, bone pain, these are all relatively sort of prevalent symptoms when people are diagnosed. But as we heard about in the interview, some people can be diagnosed incidentally. They have a blood test for some other reason. It may be as simple like an insurance medical or something like that, and they're found to have a high platelet count or high hemoglobin, and they get referred to a hematologist who will do various tests, including blood tests for JAK2, CALR, and MPL, and that will often allow us to make the initial diagnosis. Subsequently, many patients will go to have an abdominal ultrasound, mainly to look at the size of their spleen, and a bone marrow biopsy as well. But not everybody needs that. So that's really how MPNs are diagnosed. And the final couple of minutes, what's the main problem, the main symptoms? And of course, the one that like doctors tend to worry about most, the risk of thrombosis, because MPN does increase the risk of thrombosis, particularly people who've had a blood clot before, or older people, particularly people over 60, and sometimes people who've got other risk factors like diabetes or high blood pressure. This is a picture of the little things in the middle of platelets surrounded by red cells with fibrin strands surrounding them. Sometimes it can be a big spleen. This is someone's spleen that's about 5 times bigger than it should be, and that can cause abdominal pain, can also compress the stomach, causing up that early satiety we talked about a moment ago, and we try to have a meal, get halfway through it and feel full. Now, these are the symptoms which are most sort of commonly reported. This is a study that Claire published 6-7 years ago. And you can see across the board, so yellow is T, brown is PV, and blue is MF. Fatigue is by far the commonest symptom. And fatigue is much more common in people who've got MPN compared to people who don't. Abdominal discomfort, now we think of that as being a problem related to enlarged spleens, but actually you can see it in people in ET who don't necessarily have an enlarged spleen. Again, night sweats, classically we think that's a symptom of MF. You can see that's actually not uncommon in people who've got ET. Headaches are more common in ET, and some patients know that their platelet count's gone very high because their headaches get worse. And a whole variety of other symptoms, including mood changes and depression. So, variety of symptoms, I think it's really important. I encourage all the patients we see in our clinic to keep a record, to do a MPN SAF form, so we can get an idea of whether symptoms are getting better or worse. Sometimes low blood count, that can either be related to the disease itself, particularly myelofibrosis, or sometimes it can be related to the treatment. We might say, ask someone to start, suggest they start interferon to try to bring their hemoglobin down, but it may inadvertently also bring their platelet count down. So a rare problem, but people who've got ET, if they've got very high platelet counts, say over 1500, it's a risk of bleeding. We see that from time to time, it's not particularly common. And then this is, I think, certainly patients I talk to and from surveys as well, this is, I think, the thing that patients in many cases worry about most, is transformation to a more aggressive form, such as from ET to myelofibrosis, from myelofibrosis to accelerated phase disease, or very occasionally even acute leukemia. And this, if you're wondering, that's Dionysus and that's Damocles. This is the sword hanging over him. And as we heard in the interview, I think it is quite a common feeling to have that sense that something hanging over, even though, as we'll come on to, the prognosis is generally excellent. So generally MPNs, although they are cancers, tend to behave in a relatively indolent or kind of quiet way, and don't tend to progress into sort of frank cancers in the vast majority of cases. What we know in younger people, particularly people under 40, is that actually the rate of progression is actually significantly lower than it is for older people. So overall, I think we can be as reassuring as possible. There are three studies there which have demonstrated that fact, that the progression rate is lower. But of course, people still understandably do feel concerned about that. And I think that is something which, if you are concerned about, I would always strongly recommend that you discuss that with your clinician, because as I said, clinicians often focus a lot on the risk of thrombosis. And I know that patients often feel Actually, it's the longer term concerns that they're more concerned about. So I'm going to hand over, I think now to Anna Godfrey, who's going to be talking about therapy more. And just in broad terms, of course, the challenge with therapy is to try to reduce the risk of longer term complications, try to maximize the quality of life, but of course, as people are often taking these treatments for many, many years, trying to minimize the side effects. So that's the end of my talk. Thank you very much for listening. And I'm now going to hand over to Dr. Anna Godfrey, who's a consultant hematologist and MPN expert at Addenbrooke Hospital in Cambridge. Thank you very much.
Hi, everyone. Thanks so much, John. And just give me a second while I find my slides.
While you're peering and looking for them, Anna, I'm going to put John on the spot. I know he's been working all day. I hope he hasn't popped off to have a cup of tea. John, there's a question about what's the difference between the JAK2 and the CALR mutation.
Okay.
Would you mind just covering that maybe while Anna's screen's coming up?
Yep, definitely. So I mean, it's a good question. And so first of all, JAK2 were the first mutations that were found. And JAK2 is basically, it's the protein that communicates between the outside of the bone marrow stem cells and the inside. So if you need more platelets or more more red cells, there's a hormone in the blood that then tells your bone marrow to produce more of those cells. And the problem is with the JAK2 mutation, it's always on. Where calreticulin should normally be inside the cell, and what happens with the mutation, it sticks to that receptor on the surface of the cell. And although the JAK2 itself isn't mutated, the calreticulin stuck on the outside of it switches the JAK2 on. So it has the same effect. Now, in terms of the difference in how the patient, from the patient point of view, well, as we've mentioned, the people with calreticulin tend to be younger. They often tend to have a higher platelet count. The risk of blood clots is probably a little bit lower in people who've got the calreticulin mutation. But overall, the disorders themselves often behave quite similarly. So there are some subtle differences between people who've got a calreticulin and some people who've got a JAK2 mutation. But overall, I would still have the same consultation with them because the range of symptoms are often very similar.
That's great. Thank you, John. Sorry for putting you on the spot there. That's great. Anna, we can see your slides. They look fab.
Are they in the right view?
They are.
Okay, that makes a change. Right. Hi, everyone. It's really fantastic to be here and to see everyone. Thank you all so much for coming. So I'm Anna. I'm a consultant haematologist in Cambridge. So John's given you such a great overview of the disease, and you've heard a lot from Alice as well as Chelsea. So we've talked a little bit about diagnosis. I'm going to talk about what happens next, and it's really difficult to do this in 10 or 15 minutes. We have got some other webinars that have gone into slightly more detail about ET and PV over the last year or so, and we're hoping to do MF maybe next year. So if you want to know more, there is a bit more information out there, and obviously happy to cover specific things in the questions. So as John suggested, one of the first things that we have to do is balance up what are the benefits of offering some treatment versus the potential harms of treatment. And that's really about trying to work out how likely is it that your disease is going to cause you harm. And that's what we mean by risk stratification. So in PV and ET, we are most worried about, in terms of long-term risk, problems with the blood vessels. So what we call vascular events, which means a clot or a bleed. And we know that in general, for patients with PV and ET, there are certain things that put you at higher risk of having blood clots and bleeding in the future. One of them is age. So if you're over the age of 60, we call that high risk. That probably doesn't apply to anybody here. But if you've had any previous blood clots or significant bleeding, then that does increase the risk in future. Or for the platelet count, if that's very high, typically we think about over 1,500, that actually increases the risk of bleeding, not particularly thrombosis, but mainly bleeding. So we do risk stratification to try and work out what kind of treatment we should be offering to reduce the blood counts of any at all. In myelofibrosis, which I'm going to talk a little bit less about today just because it's less common, but what we're really doing more with risk stratification is asking how likely is it that you're going to come to serious harm from the illness. And we use a number of factors. Age is one, so age 65, I don't think anyone's going to be in that category, but if people have anemia, significant symptoms, so weight loss and sweats, a high white cell count or blasts, which are immature white cells in the blood, and then we use a range of genetic testing now to supplement that information. And mainly mainly in myelofibrosis, we're thinking about, is the disease worrying enough that we need to be considering treatments that have potential complications? So one of those is stem cell transplant, but as alternatives, medical therapies or drug trials. So if we then move on to therapy, what are we really aiming for? And I think John hit it on the head. As doctors, we get very focused on preventing thrombotic and bleeding events, but there's lots of other things that we would like to be able to do, and I suspect that you would like us to be able to do as well. So one of those is managing symptoms, and John's been through those really nicely. We would like to be able to reduce the risk of transformation. It's not something that we've got fantastic treatments for at the moment. There are certain special situations that we want to look after. Pregnancy is one in particular. And then we want to minimize the side effects of treatment that we're having, and also recognize the impact on emotional and psychological well-being, and to support that. So just some specifics now about broadly how we manage these conditions. So for PV and for ET, a lot of what we're doing is trying to look after your blood vessels for the long term, particularly for people who have got a long disease course ahead of you. So we can look after your blood count, but actually it's just as important that everyone knows that smoking is not good for your blood vessels. Weight and exercise management is really important. And then as you get older, we make sure that people are having their blood pressure, their blood sugar and their cholesterol checked on a reasonable basis, because problems like this are common in the general population, and everyone has to have keep a close eye on them. In general, in PV, most people will be recommended to take aspirin. So that's a drug that stops the platelets working so well. And the reason for that is that there was a study some years ago now that randomized people between taking aspirin and not taking aspirin, specifically in PV, and it reduced the risk of thrombosis. And then in PV, we want to control what's called the hematocrit to a level of less than 45%. So I hope you can see my cursor here. The hematocrit is basically the percentage of your blood volume that's made up by red blood cells if you separate out the water, or plasma as we call it, and the red cells in a tube. So this is average hematocrit, and the hematocrit here is much higher. This person's got many more red blood cells as a proportion of their total volume. And we want to control the hematocrit in PV to less than 45% and keep it there. And the reason we think that's a good target is we've actually been doing it for a long time, but a study that was published around 10 years ago by the Italians actually randomized people with PV to either a target hematocrit of less than 45% or 45 to 50%. And in terms of important events that happen, so things like strokes, heart attacks, blood clots, they were less common in people who had a target hematocrit of less than 45%. So we think that aiming for a target hematocrit of less than 45% is a good one for patients with PV. How do we do that? So in many patients, we can do that with venesection or phlebotomy alone. So taking off a pint of blood once in a while on our day unit. And we generally think that's quite acceptable for PV if people don't have any high risk factors. So when do we think about drug therapy on top of that venesection? So if patients have these high risk factors for vascular disease, one of those is age, again, probably not for the people here, but if you've had previous thrombosis or a lot of other vascular risk factors, then we think about it. If people have venesection, but either it doesn't work very well and they need an awful lot of venesection, or if it causes them side effects, they don't tolerate it very well, then that can be a reason to think about drug therapy. For some people, if the platelet count goes very high or if the white cell count is rising, then we're a little bit uncomfortable sticking with venesection alone, because venesection won't bring those other blood counts down. It only affects the red cells. And then for people, if they have additional symptoms or occasionally an enlarged spleen, then we sometimes think about additional treatment as well. What about ET? Well, ET is actually quite similar in its principles. So again, this is something where we want to look after your long-term vascular health, and managing those other risk factors is just as important as looking at the platelet count. For aspirin, things are kind of gradually changing a little bit in the field. So as I mentioned, we have good evidence for aspirin in PV, and that has generally been extrapolated to ET, although no one's ever done the study quite so well in ET. As John's just told you, ET is a much more heterogeneous disease. So some people have a JAK2 mutation, some people have a CALR or MPL mutation, and some people we can't find a mutation at all. And in the group of people where they haven't got other risk factors for vascular disease, it's less clear whether everyone definitely needs to have an aspirin. So we generally recommend it for people who have a JAK2 mutation. I'll just take you briefly through this study to explain why that is. So this was a study published a few years ago now that looked at people who have low risk disease, so younger patients without any previous vascular events. And it looked at patients who either had or had not received aspirin. And if you look at this first red box here, these are the patients who have a JAK2 mutation. And you can see that the number of venous thromboses was much higher in the patients who were just observed rather than the ones who had aspirin, whereas the numbers of patients who had bleeding was quite similar. So it seems that aspirin may be a good thing in the context of JAK2. However, for patients who had a CALR mutation, actually the numbers of events with venous thrombosis were quite similar, whether aspirin was being taken or not, but the number of people who had bleeding was higher in the people who took aspirin. So this was really the first suggestion that maybe aspirin isn't the best thing for everybody, but I think things are kind of gradually changing in the field, and there's probably a little bit of variation in practice. So when do we think about drugs to reduce the platelet count? So we heard about Chelsea's therapy today. So if patients are over 60, definitely recommend medication. Otherwise, if there's been a previous significant history of a blood clot or bleeding, then we think reducing the platelet count is a good thing. If the platelet count gets as high as 1500, then we become a little bit more worried about the bleeding risk. And again, we tend to recommend treatment to bring that down. There's nothing magical that happens when your platelet goes from 1490 to 1510, but that's roughly where we think about it. Or occasionally we offer treatment if people have particular symptoms, and the difficulty there is always whether the treatment will actually improve the symptoms without having more problems in terms of side effects. The reason that we don't generally recommend treatment to reduce the platelet count in everybody is as a result of this study, which was called the intermediate risk arm of PT1. So this looked at a big group of patients from around the world who had who were aged between 40 and 59 and didn't have any high risk factors for thrombotic events. And here what we found was when we randomized people to either aspirin alone or hydroxycarbamide, which is one of our drugs to reduce the platelet count, and aspirin, we found that the number of vascular events was exactly the same in the two arms. So it doesn't really seem that adding hydroxycarbamide is of benefit in terms of vascular risk for people who don't have these high risk factors. If we do need to reduce the blood count, what do we use? So the commonest treatment that we often recommend as a starting therapy in both ET and PV is interferon alpha, typically used first line in younger patients. An alternative drug, which is often used in these conditions, is hydroxycarbamide. That tends to be the first line drug in considerably older patients, which is more of our patient population, but not you guys. And that tends to have quite a low rate of side effects in that age group. If people don't get on with their first line treatment, they can go from one to the other. And then, as we heard earlier, anagrelide is an alternative treatment which works in quite a different way to hydroxycarbamide. It specifically affects the platelets. We've just had approval from NICE for a JAK inhibitor called ruxolitinib, which can now be used in patients who have PV and who are refractory or intolerant to hydroxycarbamide. Again, that has some side effects. And then there are some other drugs that we tend not to use in younger patients because of longer term risks. What's on the horizon? Well, there are various novel agents in clinical trials, which is really exciting for the field now. And we're also doing a clinical study in the UK looking at whether ruxolitinib is a better first-line treatment for patients who have high-risk PV. I'll talk a little bit about interferons just because this is the group of drugs that are probably most likely to be relevant to younger patients. So there are two drugs. One is called Pegasus, or PEG interferon alpha 2A, and this is a drug that's been known for some years now to control counts quite effectively in both conditions. It's not a licensed drug, although we use many unlicensed drugs in medicine. It is generally available and funded in the UK and is used elsewhere in the world as well. Everyone needs a very different dose. It can vary quite widely. And one of the reasons it sparked a lot of interest is because, unlike some of the other treatments that we use, a proportion of patients have what we call a molecular response. So a molecular response is when you measure the proportion of the cells in the blood that have, for example, the JAK2 mutation, and then you watch that proportion of cells over the course of time. And this is a study going back a few years now, looking at patients with PV and ET. These are their clinical responses on the bar chart, but they also looked at molecular response, and all these patients had a JAK2 mutation, and you can see that around 40 to 50% had a reduction in the proportion of cells with a JAK2 in the blood, with some patients overall around 10% actually having the JAK2 being undetectable at the end of their treatment. And some of those responses have now been shown to be quite durable. The alternative drug that's available elsewhere is a drug called Besremi, or ropeg interferon alpha 2b. So this is a fortnightly injection. Pegasus is more often weekly, but sometimes we can spread it out. Besremi has been shown to be effective and safe as an alternative to hydroxycarbamide in a randomized study in PV. And there's also been a more recent study trying adding that drug into venesection and aspirin for patients who have low risk PV, and it did improve the treatment responses, so you're more likely to remain in hematological response with Besremi as opposed to not having the drug, although of course there is the potential risk of side effects. So that drug actually has a license in PV, but it's not currently funded in the UK, and we hope that may change in the future. What about side effects? So everybody's different. I think it's really important to emphasize that some people tolerate these drugs brilliantly, others people just don't get on with them. The common things are things like fatigue, generally feeling a bit fluey, aches and pains. We have to keep a close eye on the liver function, lipids and glucose metabolism, and we may see changes that actually don't require any treatment, but occasionally they do. Interferon can affect the mood. So for people who have significant history of mental health problems, we have to be a little bit more careful about that. And it can occasionally cause changes with the thyroid or other autoimmune problems, which are less common, but potentially important. I just wanted to put in a slide on symptoms because really, as we've alluded to so far, we're very good at focusing on vascular risk, but actually what probably bothers you guys more is the symptoms. And I don't need to tell you about all the symptoms that are well recognised because John's done that already, although again, just to emphasise that the top one is fatigue. In terms of what we can do about that, then probably there are other people in this seminar who are actually better qualified, and that's you guys, the patients who are living with it. But it's important to think about non-pharmacological strategies, so things that are recognised to help with fatigue in these kind of situations are some regular gentle exercise. There's actually been a specific study looking at a yoga intervention. This was in the States, which did show improvement in disease-related symptoms in this kind of early study. And then in terms of pharmacological approaches, if patients have quite severe symptoms, then one of the things we can try is just controlling their myeloproliferation with interferon. And I would say sometimes that works, sometimes it doesn't. It very much depends on the individual. We have now new pharmacological approaches which are now available in routine practice. So for example, symptoms such as itching in PV can be considerably improved by the JAK inhibitor ruxolitinib. And then we're now seeing new pharmacological approaches coming into clinical trials. So for example, in PV, there's a very new approach, which is changing iron metabolism. So rather than depending on venesection, where we're basically depleting the whole body of iron, meaning that the whole body system can be struggling because of iron deficiency in all the tissues, this actually depletes the ability of the bone marrow to use iron properly, but doesn't deplete whole body iron stores. And that's very much a drugs in clinical trials, not yet available. And then in ET, some new drugs which work via very specific mechanisms that involve a system of processes called epigenetics. And at least one of those drugs is reported to improve not only the platelet count, but also fatigue. And that drug is going into a phase 3 study in the UK next year. I've just got 1 or 2 slides on myelofibrosis, and really the aims of therapy here are to do our best at the start to look at the potential prognosis of the condition. That's not giving you a life expectancy. That's just saying, on average, how likely is it that this disease is going to cause you a problem? There's lots of different scores that we use to look at that. Some of them depend on age, blood count parameters, and we often now use genetic information based on the bone marrow biopsies that we do at the start. For patients who are in higher risk categories, so we sometimes call them intermediate 2 and high, depending on the score, then really the first question is, should we be thinking about an allogeneic stem cell transplant, which can be from a sibling or unrelated donor? If a transplant isn't appropriate for some reason, sometimes people have a lot of other medical problems, or it's very difficult to get a donor, then there are alternative options for symptoms, such as JAK inhibitors, other drugs for anemia, or clinical trials. For patients with lower risk disease, then it's much more about symptoms. Some people actually don't have any symptoms that are significant and are just observed. If they do have symptoms, then it's thinking about the conventional treatments that are available or a trial. So I'm going to stop there. Just as a summary, we talked about risk stratification, which is mainly vascular events in PV and ET, and then management of long-term cardiovascular risk, antiplatelets for many people, certainly most people with PV and some with ET, and then in PV controlling the hematocrit to 45%, in ET controlling the platelets if the patient's otherwise at high risk, which is not everybody by any means. And then in myelofibrosis, using those prognostic scores to offer treatment according to the long-term risk. And I think really for future, what we'd all like to see is better approaches that really help with the symptoms associated with MPN and also allow us to modify the underlying disease so that we can address that risk of long-term transformation. Right, I'm going to stop there and come out of my slides. And I think I just have to introduce Professor Claire Harrison, who is a long-standing friend and colleague from Guy's in London and is going to talk to us about some specific topics for young patients.
Amazing presentation, Anna. We did give you a really tough job, didn't we? Explain the treatment of MPNs in 15 minutes. Fantastic. Okay, I'm going to have a go at sharing my screen. That was absolutely amazing. Lots and lots of clapping here. So I'm hoping that you can see my screen and I'm hoping that it's in slide view. Mission impossible to talk about everything related to young people. And I think that, you know, the young group that Alice has set up will hopefully really support that. There are, as we've identified, many issues that deserve mention: lifestyle, life choices, money and family matters. These are all difficult things where your teams can support, but we won't have all the answers. So there are, you know, broader areas that broader things that or people that you can reach to for support. And I think Gavin's going to talk in the next session about what you might expect, what support you might expect from a teenage and young adult service. I was also given the brief to talk about pregnancy, contraception and fertility. Thought it was important to reference information for men because we tend to forget you chaps when we talk about this. One of the key things just to remember is that some of the medications we give, really, you shouldn't get your partner pregnant when you're taking them. And they generally include these ones listed here: hydroxycarbamide, macrolide or ruxolitinib. It's not a disaster if your partner does get pregnant, but it's good to avoid if possible and have a chat to us urgently if it does happen. For contraception, what of the contraception options might be reasonable? Here, I'm talking about female patients, obviously. All of these are fine, with the exception of the combined oral contraceptive pill. And the reason that we would say no to that is because of its increase in risk of thrombosis. What do we know about pregnancy and MPN? Actually, quite a lot. No randomized studies here, but lots and lots of literature. And we know the most about ET because it's the commonest condition, and it's because it's the commonest condition for women with ET. I'm not going to show you all the literature, but I'm going to show you a couple of recent studies. The first one is this collaborative group. I've shown you some data, or I've shown some data at MPN Voice meetings from this group before. This is a European haematology group, which has got a special interest in MPN. And we had Jean-Christophe Ianotto, who's a physician in breast, at Guy's for a year on sabbatical, and he collected lots of data about young patients, so diagnosed less than 25. This was the kind of split of the patients, and I've included this just to really show you how much more common ET is in patients with this demographic than PVERA or the other conditions. Concerning maternity, of 119 women, there were 214 pregnancies. So many women who were pregnant got pregnant twice. There were 134 live births with a success rate of about 78%. Now, when you look at this kind of data, it's really important to remember that about 1 in 8 to 1 in 10 women without an MPN who are otherwise healthy will have a miscarriage or a problem in pregnancy. But this is slightly lower than we would expect in a healthy population. Of those who had medication, and we'll go through what medication we would use and why, most of those patients who were on medication were on interferon, and they were switched over from hydroxycarbamide or anagrelide because, much as we don't like men to get their partners pregnant when they're taking these drugs, we don't like women, where possible, to get pregnant when they're taking them. Again, it's not a disaster if an accident happens, but you should be in touch with your team as soon as you have a positive pregnancy test if you are taking one of those medicines. At the same time, in Sweden, and this is a bit of a complicated slide, but I just want you to focus on the fact that there were 342 pregnancies, and for the most part, these were successful with the same success rate as we described. Some of the problems that were seen by patients were having a baby that was smaller than expected. So this is what happened in MPN patients here in this column. This is what happened in a control match population. These are the patients with MPN after diagnosis, and this is control. So this p-value here, anything in red, means where MPN is different from the control population. So it's more likely to have a smaller baby, more likely that the baby was born early, but sometimes we will bring a baby, we'll induce a delivery because a patient has got MPN. So this data, it looks complicated, but it's actually quite reassuring. For ET patients, we also have to think about, is there a difference between the driver mutation and outcome of pregnancy? While we've discussed that, increasingly we're thinking that perhaps calreticulin or triple negative ET patients might have less therapy. That's what we mean by de-escalated. In pregnancy, the literature is quite conflicting. And for example, recent data from Canada suggested that JAK2 positive or triple negative patients had a greater risk of higher pregnancy loss, but this is only looking at 29 patients. Currently, our practice at Guy's and St Thomas's and across the UK really is not influenced by mutation status. So what is the practice in pregnancy? So I'm going to divide up what I'm going to say now in brief to into these 4 stages. So preconception, before you get pregnant, have a conversation with your doc. We will counsel you, do an assessment of risk. If you've already had a blood clot, you might be on a blood thinner, and you might be on some of these treatments that we don't necessarily advise in pregnancy. For example, warfarin, which is a blood thinner. And we would advise either switching the treatment when you get pregnant or switching before. In particular, we would switch a drug like hydroxycarbamide to interferon in advance of you getting pregnant. And we would want you to be as healthy as possible. So we would say address cardiovascular risk factors. And something I haven't written here, but I would generally say, is that pregnancy outcome, even in a healthy person, pregnancy is more risky the older you get. And in the current day and age, we women tend to leave pregnancy until quite late. So I would generally say, try not to be caught out and leave pregnancy until you're 40. Sometimes there's no choice around that. But if you're kind of prevaricating and wondering about it, generally, you know, a pregnancy when you're younger is less complicated. When you get pregnant, tell your team, follow standard advice, take folic acid. Midwives are very fond of giving patients iron. Clearly, that's not a good idea if you've got PV, because it will push up your red cell count. So don't take iron without talking to your team. And that's a general point as well. We will work with your obstetric team, and we will give you low dose aspirin if you're currently on it. We might do venesection, it's okay in pregnancy, and we generally operate a lower target. We would offer a different type of blood thinner to warfarin if you've got a risk of clot or if you've had a problem in a previous pregnancy, and we will do regular scans. Some pregnancies we would regard as high risk. It's much the same as Anna was saying, sometimes there's a high risk disease and we would escalate treatment. This is also sometimes true in pregnancy. So if you already had a high risk MPN, you would have a high risk pregnancy. But there are also some complications that might have already happened in a previous pregnancy, for example, early miscarriages or the birth of a very small baby, which would make us want to escalate your care in pregnancy and give you drugs such as interferon or a blood thinner such as heparin, and certainly monitor your baby and your baby's growth more carefully. After delivery, we know that the body switches over to having more sticky blood, and so we would offer in general a blood thinner for 6 weeks. So this is true even in the non-MPN population. We're very cautious about blood clots after a baby is born. We don't give non-MPN patients heparin, but we know that blood clots after pregnancy are problematic. We'd have a discussion about breastfeeding according to different drugs, and we'd discuss contraception. And a common question that would come up at this time is, should your baby be tested for MPN? And the answer to that is no. As John mentioned, there are rare families with this condition, but in general, we would not test a baby. They often have quite high blood counts, so it can be quite stressful and misleading, and usually the mutations associated with MPN come up later in life. So I'm going to stop there, acknowledge and thank everyone who's given data for this and patients who've taken part in these studies. And I think I'm handing over now to Gavin, who is our lead nurse for teenage and young adults, and to whom many patients, certainly at Guy's and St Thomas's, owe lots of support. So thanks very much. And Gavin, I think it's over to you now.
Yeah, it is. Bear with me, I'm having lighting issues. It's either too dark or too light. Hang on.
You look like you're in the hospital. My light goes off because of right. How's that going?
Hopefully that's not too bad.
I'll let you set up, but Anna, did you want to just comment on whether patients should have a bone marrow biopsy if they're JAK2 positive while Gavin's getting his slides up?
Yes, I mean, I'm not sure the question is any different if you're JAK2 positive or if you have another mutation. So my view on this is that sometimes it's helpful to have as much information as possible at the start. For myelofibrosis, yes, you definitely have to have a bone marrow biopsy. And if we're trying to make a diagnosis without JAK2, CALR or MPL, then absolutely you need a bone marrow biopsy. For ET and PV, it's a little bit less certain. One of the reasons that we offer a bone marrow biopsy is because the disease can change over the course of time, and sometimes knowing what it looks like at the start, particularly if you're about to start a treatment that reduces the counts, I think that can be helpful. But actually there are circumstances where if we had a good look at the blood down the microscope, the blood count isn't particularly unusual, the spleen isn't very enlarged, and there's no real concern that there's nothing else going on. Actually, the bone marrow results don't necessarily change the recommended treatment. So I don't mandate that people have one if it's PV or ET, but we have a discussion about whether they'd like all the information at the start.
Brilliant. So firstly, thank you for asking me to come along. It's great to be here. So I work as the teenage and young adult lead nurse over at Guy's Hospital. So I work very closely with Claire and her MPN patients. And the way that we help support young patients is we have a weekly clinic. Now, this is a weekly clinic for all types of cancers, not just MPNs, but every MPN that comes through Claire's that's between the ages of 16 to 24 gets referred into our clinic. And if a young person is below the age of 16 when they're diagnosed, when they get to 16, then they are very welcome to be referred into us. So the weekly clinic is like multidisciplinary, of which I am the nurse part. And every week in our clinic, we have a psychologist, dietitian, an organisation called Young Lives versus Cancer. You may know them by their previous name, which was Click Sergeant. The new name is Young Lives versus Cancer. And they are a charity of social workers. And in our clinic, we also have a lovely fertility consultant that gets to see all the patients. So when the patient comes to our clinic, there's no particular order. They arrive, and then one of the team will call that patient in, talk to them, see how they're getting on, and then they'll go back into the waiting room, and then they'll get called back in to another room until they've gone around the whole clinic and they've met us all. At the end of the clinic, we then have a post-meet and we talk about patients that we've seen, and that can generate a lot more work that we need to do with them. So lots of ongoing referrals are needed. So physio and OT, that's a lot of the time that's down to the fatigue that they're feeling. We also link into organisations called Trek Stock, which is a wonderful London-based organisation that helps support young people up to the age, I'm not sure if it's 40 or 39, with ongoing cancer support. And then we also have a charity called Move, and they offer 8-week programs for people, again, that have gone through cancer treatment that may be feeling quite fatigued, to help them hopefully move on and be able to get rid of some of this fatigue feeling. From the clinic, we also then have further one-to-ones. They can either then sort of set up one-to-ones with me during the time in between their clinic appointments. Some patients like to have weekly calls, video or telephone. Some people just like to be checked in every now and then, and some are quite happy just to come and see us at their clinic appointments. We can offer sort of support via face-to-face, by text, by email, telephone or video calls. Some patients we find like text messaging. You can just have a few texts, and that's sometimes enough just to help them with any issues that they've got, but it means that they can carry on their daily routines without too much interruption. And then from the appointment, potentially, if psychology is needed, because again, as John and Anna have both said, obviously, there is a lot of some low mood and some depression that comes with an MPN diagnosis. So our psychology is there. We currently have 2 psychologists, and we're waiting for our lead psychologist to come back from a sabbatical next year. So they're running groups as well. So the hope is that they would run an MPN group so that they can focus mainly on the MPN patients. So that's hopefully coming up soon. And then with the follow-ups for these young patients, I put mainly patient decided, because some like 3 monthly support, even if they feel relatively stable and not too many concerns, they like the fact that they can come in every 3 months and see us, but we do 3, 4, 5 month or 6 monthly. But as I said, patient decided usually. And then outside of the clinic, then I would regularly text every single patient. This was probably maybe every other week. It will be a text message just to sort of remind them that I'm there, asking if there's anything I can do for them. And what that normally promotes is, oh yeah, glad you text, because actually, yes, there is something that I'd like you to do or some help with. And we have done patient satisfaction surveys over the years, and the text message always comes out very, very highly evaluated. It's something that they can do. They can be with their friends, but they can send a text back, and their friends don't know that they've done that, and it works really well for them. So that's really our TYA clinic. And then what's really important is peer support for young people. And we're very lucky that we work with an organisation called the Emily Ash Trust, which helps fund our events that we do. So what we try and do is monthly events. Even through COVID, when we weren't able to do face-to-face, I organised monthly quizzes and board games that we could play online so that they could still engage with each other. For the types of things that we do, we have every other month we have a cinema and pizza evening, which works really well. We have a lovely cinema at Guy's Hospital. We do theatre trips, restaurants, bowling, escape rooms, shuffleboards. We've even been to a zoo, which is great, because the one thing that all our patients tell us is that they thought they were the only young cancer patient with a cancer diagnosis. And we literally hear this all the time. So for them to be able to get together and actually see each other and being able to talk to each other about their cancer is really important for them. And it's lovely. Towards the end of the evening, you can see them getting their phones out and swapping numbers and things like that, which is really important. And that's why we do these events, because we really see the impact that it has on these young people. Things that we can do. It's always nice to do nice things. As we always tell them, we're the nice clinic. We're not going to be taking blood from them. We're not going to be, sadly, giving bad news. Sometimes we're just there to work alongside their cancer-specific teams, and we work really closely with them. And there's things that we can do. So the Willow Foundation takes applications up to the age of 40. It's a special treat based within the United Kingdom. It can be a day thing, or it can be a long weekend somewhere, but just something that will bring a smile to their face. Obviously, if they're a little bit younger, then we can use Make-A-Wish. Twice a year, we get allocated a lot of spaces to go sailing with the Ellen MacArthur Cancer Trust, and then they do that in the Solent. They don't have to sail, and that's there to help with build low confidence, self-esteem. And then once they've done it once, they get an opportunity to go back. And when they've done it 3 times, they then can become a volunteer helping the next set of people that are coming through, which is really lovely. Obviously, there's Macmillan, and then Young Lives versus Cancer, as I said before. They register with them and they get a grant, a one-off grant of £100, which can help towards hospital costs of travelling. And then we work with lots of various charities, usually accessed via Young Lives versus Cancer, to help out financially. They get lots of gifts or treats, or they can even get shopping vouchers to help with costs. And then I thought what was really important is to have quotes from MPN patients about our TYA service, because I think that's really important that we hear their voice. And obviously this is MPN Voice, and here are the voices. So I won't read them out to you because that would be boring for you to hear my voice read that, but I'll just leave that there for a few moments so you can see some of the lovely things that have been said about our teenage and young adult service.
Amazing, Gavin. Thank you so much. There's a question in the chat for you. It won't
Lovely.
surprise you. So James has asked, what's the age range for this? And do we have to be seen at Guy's, or are patients from other hospitals welcome? So it would be good to talk about the kind of national network of TYA centres. So
for my patients, they need to be seen at Guy's, King's, St Thomas's, and then local South East London hospitals that get referred to us, and it's 16 to 24 at diagnosis. But what we would do is, if an MPN patient was referred to us 24, nearly 25, we would keep them in our service for at least 2 years so that they get the benefit, because we're building up relationships, and it's not always at the beginning that a patient is going to open up to you about how they're feeling. They need to sort of like feel that they've got that relationship. It doesn't quite sit easy with us, because if someone is 25, then we can't bring them into our service, even though we can keep them if they've been diagnosed before 24. So the service that we run is just for us, for the guys' patients. As I said, I'm not sure what other hospitals serve, but I know that a lot of teenage and young adult services around the country are building themselves up, and I don't know necessarily what they have to offer, but it's worth asking. Principal treatment centres are around the whole of the UK, and any Guy's would be classed as a designated hospital, so we feed into the principal treatment centre. Our principal treatment centre is the Royal Marsden, but there are principal treatment centres all around the country. So it's always worth linking in with one of those to see what sort of support they give for their teenage and young adult patients, especially around the country.
Amazing. Now I'm going to bring Alice in, because I can see Rich M. You've asked a question in the chat. Alice, the question, I'm sure you can see it. The TYA clinic sounds really good. Are there any clinics or similar support for 24 to 40 age group, particularly social side of meeting people in the same group? Alice.
Yeah, thanks, Claire, and thanks, Rich. I mean, I personally really benefited from the TYA service and Gavin's care particularly. I've tried to take, you know, the advantages of the social side of that into the design of the young patient network. And so we're really hoping to fill a space for those that don't have the opportunity to have a service like the TYA at their own hospital. And we're fantastically supported by Megan, who's our social secretary. So we have a committee in the Young Patient Network, and Megan has been doing a fantastic job of doing some socials, and to date they've been online, but everybody in the network is welcome. It's a really great opportunity to just chat with other people who are going through the same things, have the same diagnosis, and hopefully that's going to increase over the coming years. So I would really encourage you to join the Facebook group and keep an eye on posts from Megan, because it's fantastic that we have this social aspect to the network.
Amazing, Alice, and amazing to everyone who's been involved in setting up the Young Patients group. Francesca's asking, are there going to be any in-person forums for teenage and young adult patients? I think that one's coming back to you, Alice. So I'm guessing it's in progress, isn't it? But there is a breakout session coming, yes.
Yeah, there's a breakout session coming at the London Patient Day. Claire, you can maybe assist me with the exact date of that. But we're hoping with the breakout group, again, just to facilitate people meeting other MPN patients, talking about the issues and concerns that really matter to young people specifically. And yes, I would really hope that further down the line, we can work towards an in-person forum, because again, it makes such a difference to meet in person and to hear the fantastic talks that we've heard today that are specifically about young patient experiences, just because so much of the literature is understandably directed towards older age groups, given the average age of diagnosis. But hearing this kind of tailored information is so valuable.
Super. And I think there are there's certainly TYA services in Scotland. Now, there were lots of questions submitted in advance of the forum, and I think some of them we've answered, but there's one about types of mutations that might speed up or slow down progression. Don't know whether, John, you might want to answer that one.
So, I mean, it depends sort of what you mean by mutations. So, if it's the driver mutations, not really. So, some suggestions sometimes that people who've got triple negative disease, the absence of the driver mutation, may have a disease that progresses a bit quicker. But I think the main thing is whether there's any additional mutations. So sometimes when people are diagnosed with MPN, we find a JAK2 or calreticulin, we may do what's called a gene panel, and that will potentially identify other mutations, some of which we call high-risk mutations. And if we can detect one of those, then that will potentially tell us that that individual might be at risk of transforming or progressing to a different form of disease a little bit quicker. But it's also statistical in the sense that it just tells us of 100 people that you're more likely to transform if you've got that mutation, but nothing will give us a really kind of clear, precise guide to you as an individual, I'm afraid.
Okie doke, and I answered the question in the chat about saving a cord blood stem cells, but I would generally say mixed about those, because usually we don't get enough stem cells for an adult. There's a question about if you're 40 years old, low risk patient, is it very important to keep the hematocrit at 45? Asking because venesections reduce not only the hematocrit, but many other important elements in the blood. Anna, that was in your area. Did you want to come in on that one?
Yeah, so I'm not sure what's meant by the important elements. It certainly reduces the iron level, and that's how it works. We're depleting the body of iron so that it can't continue to make red blood cells, and that may have its own problems, but it doesn't deplete for example, the white cells or the platelets. And what we do know in PV is that the thrombotic risk very clearly correlates with the hematocrit. So before we had any treatment for these conditions, the life expectancy was about 18 months because of the risk of the blood count going very high and causing thrombosis, which is obviously a very different situation to how we currently look after this condition. So in general, because we think that less than 45% has a lower thrombotic risk than above 45%, that's what we aim for.
Yeah, that's great. And I can see you answered a question on interferon in the chat. And do you keep your questions coming in the chat if you've got questions that you want to ask? But Anna, I hope you don't mind me asking you 2 questions in a row. Did you want to comment on side effects of interferons? There's a particular one about thyroid disease, and also about, is there a maximum amount of time that a patient can be on interferon? Thank you.
Yeah, so side effects, I mean, I've talked about generic side effects. There was a question about thyroid problems, and actually I've never had a patient develop a thyroid problem on interferon, though it is well recognized, so I looked it up last night. And the interferon can affect the thyroid in several different ways. It can be an autoimmune problem or not a specifically autoimmune problem. It can cause the thyroid to be overactive, it can cause the thyroid to be underactive, and really depending, the first thing to say is that you can sometimes identify people who are at higher risk of that. So some people will have antibodies in their blood to proteins that they have on their own cells, and some people actually have antibodies to proteins in the thyroid without knowing about it. If you're one of those few people, that can increase your risk of developing problems when you go on to interferon. But actually, people who develop thyroid problems on interferon, this is actually a widely used drug for other areas of medicine. Depending on the severity, it may require the drug to be stopped, but actually sometimes it can just be continued and the thyroid problems managed. And in terms of the long term for taking interferon, I don't think there's no real reason to stop the drug if we think it's continuing to give benefit and is well tolerated. Particularly some of the groups who have looked in the long term about these few patients who seem to achieve a molecular response where essentially we can't detect the JAK2 anymore. Occasionally in those patients the drug has been stopped and we haven't got a lot of long-term follow-up, but occasionally those patients remain in a molecular response. But that we don't have any patients in our clinic in whom we've stopped the interferon, but we do sometimes stretch it right out, so maybe 45 micrograms every 6 weeks, so we get it down as low as we possibly can.
That's absolutely great. So I'm going to try and answer a broad question on new treatments. So Rich M, you've asked about bomedemstat. Well done for spelling that right. We all have to practice how we pronounce these names. So bomedemstat will be in the pipeline in January, and in a phase 3 trial for first treatment and follow-up treatments. And there's also a question about calreticulin targeted therapies. So John mentioned that calreticulin is expressed on the surface of cells, and so we can target that with antibody therapies, and we probably will be running a webinar on that in the new year, and we've got some new treatments. We wouldn't exclude young patients from these kind of trials, but you have to think about risk and benefit and how much there's a need for the treatment. So again, good to discuss. So I'm going to, I think, stop here. I'm just drawing everyone's attention to Megan Laird's message in the chat. Megan is the social secretary of the Young Persons Group. Look at her message in the chat. I want to thank all the speakers, and I'm going to hand over to Nona, who is going to close the webinar. And we will try to put out the broad sense of questions, any questions that were unanswered, I'll try to put out through Maz. But Nona, I think we need to hand over to you now.
Thank you, and what an absolutely brilliant forum this has been. And Alice, it's an inspiration, and it's just lovely to see a new aspect of MPN Voice evolving. and I look forward to seeing you all at the patient day. Unfortunately, it is full, and there is a waiting list. But if you want to go on the waiting list, please feel free to do so. We couldn't do these forums without donations. If you've enjoyed the forum and you could just give a small amount of money, every penny counts, because we need to raise funds for the research projects that we're doing, and also other general costs with running MPN Voice. You can do this through the Just Giving page, and the link is there, or you can use the QR code. Or any queries, please don't hesitate to contact Maz at info@mpnvoice.org.uk. And all it remains for me to say is a huge, huge thank you to the clinical team that have worked so hard to produce such an excellent webinar, and keep well.